Everything is now 16. Mhm.
Ihe emechitekwa ụzọ maka ikuku mmiri nwere ike ịnaba. Mechite n'ụzọ. For light, it's a small light is entering from the window.
Hello, good afternoon, everyone. Can you hear me, please?
I can hear you.
All right, thank you very much. I welcome everyone to today's training on our advanced acute physio essential. Thank you all for joining. So last time we started on positive pressure. Ideally, today was actually meant to be for something else, like I think pediatric, but because we started this last time, but and I feel like this is a very, very, really important aspect that we really need to spend a couple of time on. So That's why I'm bringing this up again, so we can have a chat on some other aspects that are really very important to us as physio, and to the wider MDT as well. So last time we started on positive pressure therapy, and we spoke quite a lot about the indications for positive pressure, the contraindications for positive pressure. We spoke about, I think we're able to touch on cough assist side of it, the MIE, mechanical insufflation and exsufflations. And we'll talk a lot about why that respiratory adjunct is really very important, and why we need to start advocating for those kind of treatment adjuncts as part of our toolkit in Nigeria as well. Um, so before we go forward today, I'd like to ask if there are any questions or anything, or any reflection, or anything anyone would like to share with us, or maybe any patient they've seen recently, um, what they did for them, or anything they've picked up from all of this training we've been having so far, and anything they've implemented and that has come out as being positive outcome. Anything? Anything anyone would like to ask question-wise, clinical reflections, sharing your patient, your experience with us, with your patients, or any knowledge you've picked there that you feel, yeah, I think I've been using this in my practice so far. Anything so that we can start? Then hopefully today we can also take some clinical questions, clinical scenarios, and I've also gotten some questions from guys about I think the last clinical, the exam, the text that we'll have, that they like us to go through those questions. Hopefully we can have a touch on that today as well. So anything from anyone, anything you like to share? I love reflection a lot. I reflect a lot, and I encourage people to do it a lot. That's why I'm bringing this up before we start, because this is a strong tool that we all need to develop. We all need to do a lot. If there's anything you do well, reflect on it. And if there's anything that needs improvement. Hello, can you hear me? Anything? Hello?
Can hear you.
All right. So no one is sharing anything with us. All right. So today I'll just go straight away to NIV. Just walking through my slide now. It's a huge slide. So today I'd like us to quickly have a touch on NIV, but just few seconds on, or few minutes on what we did last time, specifically about cough assist. Cough assist, again, I'm saying it again, very important respiratory adjunct. We need it. I still use it overnight. Went down to see some patients. It is really, really very important for us. We need this respiratory adjunct to support patients that are really, really very poorly, or even at the community level, there might be some patients that will continue to need those equipment, even at the community level, even while they are being discharged from the hospital. So they really, really need it, maybe as a preventive role or anything like that, to prevent hospital readmission or thereabouts. So remember how we talked about clinical reasoning last time about cough assist. Remember the indication, remember the contraindications. Remember when you start thinking about that equipment as physio, if, for instance, now, if you've gone to see a patient, they've got a weak cough, you've tried everything physio with them to augment their cough, everything seems not to be working for them. You might start thinking about cough assist, or you've got somebody struggling with any of the phases of the cough. It might be inspiration, it might be glottis closure, it might be expirations or anything like that, or expiratory flow. You might start thinking about cough assist. But before you start thinking, like I mentioned last time, think about every other technique you need to try before you start thinking about, yeah, let's try cough assist. And peak of flow again is also another very, very, very important thing that would like our acute physios to be running with patients, especially neuromuscular disease patients, SCI patients. We need to be running their peak of flow to know where they are, to know to in terms of risk stratification, so we can know if we need to start augmenting their cough, if we need to start some prophylactic treatment with all of these patients. Remember those things that we discussed, we won't go over those things again. So today it's going to be on NIV, non-invasive ventilations. So the idea for bringing for this training is going to be on what do we see as physio if a patient needs to go on NIV, like, because sometimes you might be on the on-call physio, you might be asked to see some patients, and they might be presenting, they might be poorly at the moment, they might be feeling sick, and there might be need for them to go on some of these to go on NIV, for instance. So what do we see as physio? And again, because this is also another scary respiratory adjuncts that maybe it could be because of a lot of nomenclature, like names, different models or different machine you can find, because each hospital have different kind of machine they use to support patients that are struggling or patients that might need to go on NIV. But it's really, all of these things really make it look complex, but in reality, these are really very simple things. And again, the goal for bringing this up is just to build our confidence, to build our maybe basic reasonings, to be able to identify patient, even if you can't commence patient, because you might need some competency, you might need some hands-on trainings on how to set this equipment up, how to commence patient on this equipment before you start patient on it. And again, clinical governance, hospital governance, again, also come in place about, oh yeah, who does it and some other things. But these are really good things. Building good understanding about this might also be very helpful to us as physio as well. So when we say non-invasive ventilations, what does it mean? Practically, generally in hospital, when we say ventilations, we should be thinking two things, either invasive or non-invasive ventilation. When we say invasive, these are patients that need to go on breathing tubes. Either they've got trachea or either they've got endotracheal tube or anything like that, breathing tube, plastic, going into their airway. That's invasive ventilations. But we are talking about non-invasive. This is just ventilations that you are not bypassing the upper airway. The upper airway is still there. They are still, just like you and I now, we've got our upper airway, everything intact. No one is breathing through any plastic in their neck or in their mouth or anything like that. So now, if you really want to support patients that their upper airway are still patent, they still have that ability to use the upper airway to ventilate, but they might need some sort of respiratory support to assist them. So we might be thinking about non-invasive ventilations. So in short, what I'm trying to pass across here is non-invasive ventilations, the type of ventilations where you are not bypassing the upper airway. You don't need any extra plastic for a patient or any breathing tube for your patient. All you've got need to get is maybe interface, face mask, or anything. I'm going to show us all of those things. So that is non-invasive ventilations. So when do we think about it? Or what sort of patient do we think might be needing to go on NIV? If I ask you guys to pop some ideas for me in the chat box, some opinion, to put some opinion in the chat box for me, let's get started. We're just warming up now so that we can enter into the business of the day. Can you guys put some ideas for me in the chat? So what sort of patient do you think might end up going into NIV? Any idea, any opinion? Yeah, any idea? Because I
maybe asthma patients.
Okay, asthmatic patient. Asthmatic patient might really be a very tricky one because of their airway compromise. And don't forget what we mentioned last. Thank you for that. First of all, I need to appreciate that. Yeah, thank you for that contribution. Because asthma patient might really be very tricky. Remember what we talked about contraindication for general positive pressure last time. If you are pushing into the patient's lungs, remember asthmatic patients, they've got issue with their airway, bronchospasm, bronchial constriction. So if we are pushing here into their upper airway, down into their lungs, that might further irritate their airways and can even worsen their constrictions. So asthmatic patient might really be very tricky. So generally speaking, asthmatic patient might not end up on needing NIV. So I suppose if they are really, really very poorly, they are, they are getting fatigued, their ABGs is being deranged or something, they might need to just go straight away if they are for full escalation. Most of them might just need to go straight away into an invasive ventilation, like full level 3 level of care, like full escalation into the ITU. So for asthmatic patients, most of the time, so this is like a sort of contraindication for them. We don't want to, because we know if we are pumping here into their lungs, to the upper airway, that might irritate them and even worsen their bronchitis. So yeah, thank you for that. Can we get other opinions? Yeah. What patient do you think? Because we need to, as clinician, we need to be able to identify patients that might go on these things. Yeah. Yeah. Good patients. Good patient. Yeah, I mean COPD. Okay, all right, yeah. So COPD patient, yeah, exacerbations of COPD. Yeah, they might also end up going on this equipment. Yeah, absolutely. Thank you for that. Kelechi, thank you for that. As any other idea, open your mic if you need to speak, pop responses in the chat box. It really makes sense when we are interacting as opposed to me doing the whole business. We are all physios, we are trained, really intelligent, and yeah, wide range of experience. So let's make it interactive. PT that's really brilliant. Yeah, COPD patient might go on NIV. Yeah. Any other patient? Any other patient? There's no right or wrong. Just pop what comes to your head, or just pop them in the chat box. Yeah. Let's see. Any other patient? Can we get a few more response? Any other patient group that will think might end up needing this? Any other patient? Yeah. All right, we're gonna, because of time, I will leave that to you. Think about it, pop them in the chat box, and I will just go on with the presentation because of time. Yeah, let me just read it. Some answers have come through. Let me see. Yeah, bronchostasis, yeah, patient with brainstem stroke. Yeah, if patient have got, yeah, we're gonna talk about that as well. Yeah, if the patient have got issues with their breathing center, yeah, they might, yeah, most of them, because we know at the moment, in the brainstem, you've your pons or medulla, you've got your, what you call now, apnea center, something like that, or if they've got any condition, it could even be neuromuscular condition beyond stroke or anything impacting their breathing center. Yeah, they might, their breathing might be really, really distressed. It might be a kind of distress for them. They might be distressed with their breathing. So they might be needing something to offload their breathing, to make their breathing more comfortable for them. Yeah, we're gonna see. Yeah. Inflammations. Yeah. Really good one. Petechica. Yeah. Pneumonia. Yeah. Patient with chest infections. Yeah. Pneumonia. Yeah. You might also go on that. Yeah. Great. Excellent. Cool. From what we discussed last time, I just really want to ask some question again. From contraindication we discussed, this is just me texting what we discussed last time. If you think about tumor patients that have got tumor in the upper airway, or patients that have got tumor in the lungs, do you think they will be going on this equipment? What do you think? Just type yes, no in the chat box, or if you want to speak, open your mic and maybe put few response, because this is just clinical reasoning based, building our knowledge about certain things. What do we think? Tumor patient in the upper airway, do you think they might end up having this? Yes or no in the box, in the chat, or open your mic. What do you think? If yes, why? If no, why? Let me see. Some answers have come through. Yes, okay. That's Piti Chika saying yes. So why do you think tumor patient might, why do you think tumor patient might go on having, let's say somebody have got cancer, tumor in the upper airway, can they have NIV? Are they suitable for NIV? Don't forget, NIV is also positive pressure. What do you think? Yeah, PT teacher answered yes. Okay. Can we have some responses? Can we have a few more? Can some answer come through? It's just me texting what we discussed last time about general contraindication, about positive pressure. What do we think, guys? What do we think? I know these are really, really looking like unfamiliar area, but in acute hospital, really have to be very, very familiar with some of these things, because sometimes you might be called to come see a patient, they are distressed, they are fatigued, they've got this, they've got that. And yeah, sorry. Other answers coming to, yeah, due to tumor could lead to blockage of airway. That's pretty chica. Okay, thank you for those responses, for that response. But what I will say is from what we discussed last time, patient with tumor, yeah, let me see another response. Yeah, no, this PT, I'm struggling with that first name. I'm sorry, Emilia. So no, because they will benefit more from invasive procedure. Yeah, okay. Now we have two different opinion now. Which yeah. So from what we discussed last time, we mentioned that when it comes to positive pressure, giving either cophasis, either IPPB, that this we are discussing today, non-invasive ventilations, you want to be really, really very careful and with your positive pressure with them, because if you up your positive pressure,
Okay. About
Didi Kamal, please. So if you give them, so if you give them positive pressure, here might be trapped behind that tumor.
Okay, 3 ni. Ẹ ṣe ní ilé ẹdún ṣe lè wọ́n bá ìdán bọ̀ lọ.
No, the last one, la vese lola.
Okay, last.
Oh my God. This is distracting us. Pity Kamal, please. Can you mute yourself, please?
Abìnrin láàárọ̀ ẹ wẹ̀ lọ́wọ́ ẹ pẹ̀lẹ́ lé o. Jonathan ni. Pẹ̀lẹ́ o. Pẹ̀lẹ́. Àdáhùn làwọn wálé ń wẹ̀ àní kan jíṣẹ́ fún yín gbogbo àdáhùn sáà rẹ̀ bá yẹ kírun tán náà lọ. Ẹ wá sà. Pẹ̀lẹ́.
All right.
Yeah.
Please, how do we meet these people? All right. So like I'm saying, so when it comes to tumor, you want to be really, really careful with pumping here into patient's lungs, shifting load of air into the lungs, because we know with tumor, especially if the tumor is in the airway or in the lungs, that those air might be trapped behind those tumors and struggle to come back out. The patient may struggle to empty them out from their lungs, and in the process, if the air is trapped into their lungs, anything can happen. Some might get bulle, some might get pneumothorax or anything like that. So really, really careful before we administer non-invasive ventilation. We want to ensure how do we meet?
Teacher náà ti ṣe farm. Agbo.
Báwọn kan tún sọ pé
àárọ̀ ìjẹmọ́ kò ní tóbi tó wọ́n. Ní ọmọ àǹtó tó yẹ pé ibi tí wọ́n ti fẹ́ jí gbé lọ irú ilé àṣebírú ẹni mo fún bàbá gbà ẹ̀ ó máa ń tóbi.
Ẹ sì gé lórí báyìí.
Nà irú ìgbó fún ẹ náà báyìí ṣe náà ni.
Àwọn lọ́dọ̀ tí wọ́n àwọn tẹ́ bá ti ní ṣe ń gé lórí báyìí àwọn kòròrò ni wọ́n gé kó lè bá tètè yára dìbẹ́lọ́pọ̀ wá kàn gé lórí ìyá rẹ̀. Kò lè tó. Àtẹ́yìn ìdààmú gbàǹgbà bíi mélòó.
People are just taking our time unnecessarily, please. Can we get the admin to just mute these people?
Ó ti dà báwọn. Ìyẹn ìsinókù báyìí ká máa béèrè. Àwọn obìnrin náà máa ń ṣe yẹn.
You should reschedule the meeting. I think there is a way you can mute every other person since you are the host.
Possible. Mo sọ ní pé eléyìí ò lè tó wa. Àmọ́ pé tí bá ṣe gbà náà ní ọ̀rọ̀ bá ń pè mí. Bá ṣe gbà náà. Yòókù ń bọ̀ lọ́wọ́. Ṣé ilé? Ọmọ kékeré kan kan fẹ́ lè náà.
Good evening, sir. Hello?
Hello, good evening, ma'am.
Sir, please, I think there is a way you can mute every other person since you are the host.
Not sure I'm the host, but let me have a look.
Bó ti rí exactly ni. Irú báyìí pọ̀ ládùúgbò wa tó jẹ́ títí. Kò ń ṣe dàbí òdélé. Kò ń ṣọ̀pẹ òkun ní. Wọ́n máa ń fi igi rẹ̀ ṣe. Àbẹ́ mi ṣeré mo sì mọ̀ pé dàbí òdélé.
Bá àdélé 500 naira mo rà. Bọ́ eléyìí mo gbé fúnra mi.
Ó sì.
Èyí tí mo gbé fúnra mi gan, eléyìí tí mo kọ́ ṣe tán, ìyẹn ti jí lọ.
Ó ní wọ́n wà lọ́wọ́ ọ̀tọ̀jú kì í ṣe bíbí.
Eléyìí bàbá yẹn ló ní pẹ́ ẹ̀mí Adédòkun lórí ta ẹ̀. Ẹ̀ náà bá ń gbé wá látòṣogún gbà ẹ̀. Bá méjì gan ni nǹkan ti kú ẹ̀fín nǹkan. Ókè.
Àgbédà ni òṣè tí ìgbàgbé bọ́ ṣe ní ìgbàgbé nípa tí ìgbé fẹ́rẹ́ pa ni.
Ọlọ́run fẹ́ dà sálọ.
Àwọn.
All right, let's continue, guys. That is really very frustrating, honestly. But let's continue. So like I was saying, if we've got a patient and they've got tumor is really a big contraindication for the use of positive pressure because we know here can be trapped behind their tumor, and to puff out those here, to get rid of those here from the lungs might really be difficult. And again, we don't know the viability of that tumor. We don't know how big it is. And so if we need to go on using any positive pressure, that decision has to be made with the medical team. We have to speak with them, speak with the ENT doctors, speak with whoever is leading the team. I mean, whichever team is leading their care, that those decisions need to be jointly made. And beyond that, so generally why I ask that question is because before you start a patient on NIV, we want to ensure that the pathway to their lungs is really very patent and clear. Meaning, even at the bedside, when you go to see patients, you want to also ensure that their airway, they are still able to maintain the patency of their upper airway before we commence this patient on positive pressure. Because we know if they have started, maybe they've got bronchial constrictions, like in the case of asthma or anything, or their airways have started collapsing, their GCS is lower than expected. Now they cannot maintain their patency of their upper airway. They might need, if they are for full escalation, we might need to bypass this level 2 ceiling of care and just move them straight into escalate them into level 3 ceiling of care, which is invasive ventilation, if that makes sense to somebody. Even though there are other clinical parameters or other things we need to check, but we're going to talk about that. But I'm just trying to build some concept from here before we move forward. So I just go on with the slide. So now somebody mentioned the other time about issues with the brainstem and everything. So I really want us to look at this slide carefully. It could give us some understanding about what it means what it means to support patients, and again, what it means if patient is coming from a poor respiratory background, and if you've got two patients now, one is coming from a poor respiratory background, and you've got another patient, they've just got acute deterioration, but if we look into their past medical history, they've not got any significant respiratory background or respiratory issues, or they've not got any significant past medical histories. If you compare their physiological reserve, it's going to be really it might be different. the patient coming from a good respiratory background might likely to do well compared to the patient coming from a poor respiratory background, if that makes sense to somebody. So what I'm saying is, okay, let's look at this picture because of time. Look at this picture now. If you have a look at this is talking about your brain. You've got, for a spontaneous patient like you and I now, we are not on any respiratory distress. We are just breathing spontaneously, doing our tidal volume, regular breathing, and all of those things. So the information, the stimulation is coming from the brainstem, from the pons, your pons, your medulla, your Hartley center. It comes down, afferent sensation come down from there. It goes to your respiratory muscles, your diaphragm, your external intercostals, your internal intercostals, all those muscles of respirations. Great. Now, we also have to think about if you go to see patients at the bedside now. This is how I think generally. I think about where is the stimulation coming from, which is their brain, their brainstem, their pons and medulla. I also have to think about what is their respiratory capacity. If that makes sense to somebody, what is their respiratory capacity at the moment? Respiratory capacity in terms of their strength. What is the strength of their respiratory muscles? What is the endurance of their respiratory muscles? How are they presenting? How do I know some of these things? How are they presenting at the moment? Are they fatigued? Are they in respiratory distress? What happens to their pump? What is their pump? Respiratory pumps, their chest excursion and all those things. How are they behaving at the moment? Think about that. In terms of breathing, look at their breathing pattern, their diaphragmatic, how diaphragm is descending, what is the abdomen, is it rising nice and falling nicely? What happened to their thorax? Are they having good chest excursion, or are they in any work of breathing or distress? Look into all of these things to judge a patient's respiratory capacity. Then again, you can now have, for a patient that has been admitted in a hospital, for instance, now, you can have a loads on their respiratory muscles, respiratory loads, something on their respiratory muscles. Like for instance, some people can have chest infections, people can have bronchiectasis, for instance, people can have COPD, for instance, people can be a chronic smoker, for instance, people can have cystic fibrosis, people can have any condition, pneumonia, for instance now. So now, what do we think? If the respiratory load is much more heavier than the patient respiratory capacity, what is going to happen? The table is going to tilt, if that makes sense. But again, think about it now. The examples I gave earlier, you can have two categories of patients. One is coming from a good respiratory background. So the current insult that is going to be on them, let's say now, somebody coming from a good respiratory background, now they are now having chest infections. Now, you've got an insult now on their respiratory capacity, now on their respiratory system. You've got an insult on that. Now, how they're going to cope with that insult will depend on what is their baseline. So that is why when we say baseline is really, really very important. If you have seen a patient at the bedside, I would normally expect that before you go to their bedside, you have read through their caseload, look into their past medical histories. Have they got any significant respiratory are they coming from any respiratory background or any poor respiratory background? What have they? Now, because they've got, for instance, now let's say somebody is being admitted for exacerbation of COPD, for instance, or they've got infective exacerbation of COPD. They've got COPD. Now, on top of their COPD, now they have infections on top of their COPD. What does that mean? They're coming from a poor respiratory background. They have already they have an insult, something impaired, like a kind of respiratory impairment. Now, on top of that respiratory impairment, now they have infection on top of it, if that makes sense. So try to think about all of these things and put it in the context of your patient. If you are going in to see a patient, have a good read of their medical notes or their medical background, their comorbidities, and link that up with their current presentations. And whatsoever they've got on top of that, how they're going to cope. How are they going to cope on top of their previously existing problem? This is what we need to start thinking about, if that makes sense. Now, I've got some questions for us to really make this thing, so that this thing can really be interesting. Now, what factor do we think can increase patient respiratory load? Of course, I've mentioned some of them, but I really want some idea from us as well. So what factor do you think can increase patient loads? And what factor do you think can also reduce patient capacity? respiratory capacity. The capacity in terms of their breathing, their diaphragm, their intercostal muscles. What are the factors that can make a patient to start using accessory muscles to ventilate? What are the factors do we think can make patients to start, the accessory muscles to start kicking in for them to be using that to ventilate? Hello, are we there? Hello? Hello?
Yes, I can hear you.
All right, thank you. Yeah, do we understand the question? My question is two questions. Whatever, anyone you are answering, just say load and put your reasoning there. If you are saying capacity, put your reasoning there, because these things are really, really very important, and it's going to enhance the way we see patients. It's going to enhance the way we see things. What do we think? What are the factors that can increase load, and what are the factors that can reduce patient capacity? Yeah, some answers have come through. Let me check. Please put your answers, response in the chat box. Yeah, we can hear you. Thank you. All right. So what do we think? What are the factors that can increase patient loads, that can burden the patient respiratory system? That is what that is saying. And what are the factors that can weaken patient's respiratory mechanics or anything, or that can impact on their, on the sensation they are getting from the brain, or that can, anything. What do we think? Because if we don't get this thing right, it might really be difficult for us to understand some other aspect of this training. So who is there? Who is helping us? Yeah. Who is there? So what factor increases load? What factor? Think about anything. I've mentioned that again. I've mentioned that before. Anything that can increase load, that can cause assault, respiratory insult, not assault, insult to your patient, or that can impair patient respiratory, anything respiratory system of a patient, can increase the load. It could be pneumonia, it could be chest infections, it could be neuromuscular disease, it could be anything can cause load. Now, when you come to something that can reduce patient capacity, what are those things that can reduce your patient capacity? Think about brainstem. What are those things that can impact patient brainstem? Yeah? Think about these things. I can't do it alone. Some answers have come through. Let's see. Yeah, we are here. External trauma to the lungs. Yeah, increased pulmonary secretions. Yes, pulmonary secretions. Yeah. Excellent. Great. Yeah, obesity. Yeah, obesity. Yeah, obesity can really put a lot of pressure on the diaphragm. Yeah. So what other things are we thinking about? Because we need to get our reasoning well, first of all. If we are not getting our reasoning well, it's going to impact whatever things we're going to be doing for the patient at their bedside. It's going to impact. Yeah. Let me see. Thank you very much. People are responding. Yeah. Physical fat. Yeah, that's pretty chica. Thank you very much. Yeah. So I will leave you guys to keep popping in that while I crack on with this because of time. Time is running. So in terms of respiratory failure, we have had training on ABGs. I would advise we go back to ABGs, check them as physio, as acute physio. Your bread and butter, you're going to be working a lot with, looking at patient ABG, making decisions with their ABG, correlating their CO2 with their pH, with their bicarb and all of those things. So we really need to familiarize ourselves with all of these things. It needs to be at our fingertip. So please go over those training again and have a look at it. So I won't go in detail, but remember, we spoke about hypoxic respiratory failure, this type 1 respiratory failure. Oftentimes when you read the caseload or when you see patient being poorly, increased oxygen requirement, 60, 40, 80, thereabout, you find the medical team or the nursing staff or specialist nurses running their ABG, or you could be you physio asking them to run ABG for you. Yeah, we do that. It could be you asking them to do that. So you can have a look at their blood gas. So now, if somebody is having type 1 respiratory failure, it's just issues with oxygen. Issue with oxygen. Anything less than 8, we have discussed. Have a look. I'm not going in details. And if it is type 2 respiratory failure, two things are failing. the oxygen is failing, they are struggling with oxygen, and again, they're also retaining CO2, hypercapnic. So that's just acute respiratory failure. Go over those things. And there is also acute hypercapnic respirations. So acute and two things now, acute hypercapnic respiratory failure and acute on chronic. So how do you know? Don't forget, for type 2 respiratory failure, your oxygen is low and their CO2, they are retaining CO2. Their CO2 is on the high side. I have explained these things on the ABG. Please go over it, this thing. So for acute, so their pH is, their pH, of course, their bicarbonate is going to be normal, but if it is acute on chronic, what is going to happen is their bicarbonate might be on the high side. Let me give you an instance, just a brief one. I won't go in detail. I've explained this thing in the past. If you've got a chronic COPD patient, for instance, we know for COPD patients, because they've got barrier chest, their chest is normally big, the issue they normally come up with, or the issue they normally have is ability to puffer CO2. So they tend to retain CO2. So in the course of retaining CO2, because our pH, the pH in our body, or let me say, our enzymes we've got in our body, the proteins or everything in our body, they like to work at a particular pH. They like to work between 7.35 to 7.45. So anything outside that, it becomes catastrophic for them. They don't like to work outside any pH less than 7.35 or any pH more than 7.45. And I have explained this thing in the past anyway. So now, but for a chronic COPD patient, what happens in their case is their CO2 is normally in the blood, so they are chronic retainers. So in the course of bicarbonate struggling, trying to balance up the pH, so what is going to happen is they will normally have bicarb high in their blood as well. That is why you have, so that is chronic hypercapnic patients. Their pH is going to be on the high side. So now, if you now got a patient that is just, maybe they've not got any significant neuromuscular conditions, or they've not got any significant past medical history, but at the moment they are struggling to handle CO2, they are retaining CO2, and that CO2 is now driving their pH, really driving it low. So what is going to happen is, normally when you check their blood gas, their bicarbonate is likely to be normal in their own case. So the difference between that chronic and acute or something is just the bicarbonate. And if you are looking at the pH of somebody, you see that the CO2 is on the low side and the CO2 is on the high side. And that, because CO2 is an acidic gas, I have explained all of these things, and that CO2 is now driving the pH to start going low. And you now look at their bicarb, and the bicarb is still normal. What does that suggest? Then I suggest that, yeah, this is looking like a kind of acute respiratory failure, if that makes sense. But if that bicarb is on the high side, it might suggest to me that, yeah, this might be a case coupled with their background of chronic conditions or neuromuscular conditions they've got, or obesity conditions they've got, or anything like that. It might suggest to me that this might be a case of chronic hypercapnic respiratory failure, if that makes sense. This is just a brief revision from what we have discussed in the past. So that knowledge is also really very relevant to us as physio, to bring those knowledge back in, to be able to work with patients that will be needing NIV, if that makes sense. Are we still here, guys? Is it making sense? Hello?
Yes, it is.
All right, thank you very much. So now, back to the previous question I asked you guys the other time. What are the patients that might be needing NIVs? You go to the patient bedside. What patient? We've got loads and loads of patients that might be needing NIV, but these little ones I've brought on, or I've brought in, might really be helpful to guide our reasoning. The first one, generally people will think about, is people that have got acute hypercapnic respiratory failure. Acute hypercapnic, they are retaining more CO2. People struggling to ventilate. Think about that. People struggling to ventilate. Their respiratory pump is failing or has failed or something like that. So now when you say patient is struggling to ventilate, what that means is now they are struggling to puff out CO2. They are now retaining CO2. Those kind of patients. Now, the implication is, if you don't support their breathing mechanics, they're going to get tired quickly, And once they are tired, once they are tired, what is going to happen is that some of them, if they continue to retain CO2, some of them will start becoming drowsy. And once they become drowsy, what can happen if you don't reverse that? Some of them might be knocked off into respiratory failure. In fact, they might even die of respiratory arrest. So we need to think about one sec. Sorry. So we need to think about how we can support patients that are retaining CO2. So now, if patient is retaining CO2, like I mentioned, sometimes when you go to their bedside, you might find some of these patients, some of them might be complaining of headaches, some of them might be drowsy, some of them might be sleeping too much, some of them might be having some flapping tremors, and so all of these clinical signs, they could really be very, very helpful when you go to patient bedside and you see their presentations. You might want to just ask the nurse, and you look at the ABGs, and even prior to ABG, and you look at their oxygen, they are high on oxygens, and they are still struggling or anything like that. You might want to be some of these clinical signs that you pick up, and you just speak with the medical team that if they can run their ABGs. And looking at the ABG, if you look at the CO2, you look at the pH, and you see that the CO2 have started driving the pH, dangerously low. It started driving the pH to start going low. This might be an indication that, yeah, this patient, if other things are okay, we're still going to talk about every other thing. If other things are okay, this patient might likely to be needing NIV to support their breathing. All right, we're still going to talk about how NIV can help this patient to ventilate, if that makes sense. You can have patients, of course, hypercapnic and acidosis, maybe chronic retainer, like if you've got somebody on top of their COPD now, they've got infective exacerbation of their COPD, or you've got somebody with bronchiectasis or something like that, now admitted because of new chest infection, they are struggling to ventilate, they are very, very, really, really very tired. Those patients might also be needing NIV to support them. You can also have exacerbation of previous conditions or pre-existing conditions. Like on top of, remember the picture I showed you earlier, already some patients might be having, like they are coming from poor respiratory background. Now on top of that, they've got new thing on top of that. Some of these patients might really be struggling to cope with the new insult or with the new impairment on their, or with the new loads on their respiratory system. Some of these patients might be needing something to offload their breathing. Think about that. You might have patients with neuromuscular conditions. You might have it's a physician, please. So you might have patients with neuromuscular conditions. You might have all right. So you might find patients with neuromuscular condition as well that are struggling with, that are struggling to ventilate, or maybe they've got reduced chest compliance. Now, we need to be careful with reduced chest compliance. Chest compliance that is not due to maybe ARDS or because of cystic fibrosis or anything like that, because we need to be careful. I think I discussed that when I was talking about contraindication. Those things are also very important that we know them. Now, again, NIV might really not be for maybe acute treatment, or maybe it might really not be for, let's support these patients. It might not really be for, let's support these patients, let's progress them or anything like that. It might also be for end of life, to support patients that are on palliation so they can have a painless death, so that they can die peacefully without, it might just be like a kind of supportive adjunct to offload their breathing, to make their breathing more easy. It could be maybe they are really, really very anxious, or they are really very breathless. It could be when we put them on these things, it could actually offload their breathing and make things more easy for them. NIV can also be useful for some of these patients. So ceiling of care, NIV can be ceiling of care for some patients. If you get a patient that have they've got maybe they are really, really very frail, so they might not be for, and they've got a lot of comorbidities and all of those things, and so So it could just be beyond the ward-based ceiling of care. So if they become poorly in the hospital, so it could just be that their highest ceiling of care is NIV. Let's pop them on NIV to support them. If they are struggling to ventilate, they are struggling to breathe on their own, it could just be, we get NIV to support them to be able to breathe by themselves. So some patients might not need to go into, not all patients might be fit, go into ITU to be intubated, to have plastic breathing tube, or to go on mechanical ventilator. Not all patients can end up in the ITU. For some patients that cannot end up in the ITU, some of them, their ceiling of care might just be this NIV to support their breathing, if that makes sense. And some patients might also be needing it overnight to support their breathing. So you can have some patients maybe overnight, there's a reduced tone in their respiratory muscles, or in their muscles they need to ventilate, because generally speaking, when everyone sleeps, of course, the tone in the respiratory becomes weak compared to when you are much more active. But some patients that are having maybe sleep apnea or obesity syndrome or anything like that, some of them might also be struggling overnight. So some of these patients might also be needing some of these equipment to support them overnight, to be able to ventilate well overnight. So this is some of these things you can some of these conditions you can think about when you go see patients at the bedside that might be needing some of this equipment. In terms of clinical signs and symptoms, I want to get back to Ross again. Because I love things to be really, really very active. So now, from this explanation I've made with all of these things, so what do you think are likely to be the clinical signs and symptoms I can see, like things I can see if I go to patient bedside? Because anyone, like I mentioned initially, anyone can actually go into NIV if there is no contraindication. If there is need for it, any patient can go in NIV. All right. Now, so the question is now, what are the clinical signs that I can see that might suggest to me that, yeah, this patient might need to go on something to offload their breathing, to make their breathing much more easy for them? What are the clinical signs I can see at the bedside? Are we still there? Hello?
Yes,
Hello?
we are.
All right, thank
Yes.
you. All right, thank you. Yeah, what are the clinical signs? What do you think I'm going to see? Because if we really want to start seeing patients that are acutely unwell, and in reality, we need to be seeing all of these people. So, our clinical understanding of clinical conditions, being able to pick up things, patient presentations, and all those things are really, really very important. So what are the clinical signs, or what am I going to see? What am I going to feel? What am I going to hear at their bedside? They might say, oh, no, I need to speak with the medical team. Oh, no, we need to get this patient on NIV. We need to get a supportive adjunct to offload their breathing, to make their breathing much more easy for them. So what am I going to see? Yeah, somebody have written whistling, that's pretty chica. Yeah. Patient might be whistling. Yeah, great. What other things can we see at their bedside? Yeah, what other things can I see at their bedside? For whistling, yeah, we also need to clarify that as well. Somebody is whistling, maybe due to secretion retentions, maybe there's mucus plugging in their airway or anything like that. But from physio perspective, before we get this patient on NIV, we should also be thinking about, we need to optimize their chest. We need to help them get rid of those secretions. Then to support their breathing, then we can then put them on NIV so that NIV can reduce their effort of breathing. If that makes sense. Why? Why do we need to do our chest clearance with them first of all? The answer is very simple. Because imagine if somebody is getting secretions in their upper airway and you are putting here, you just dump mass in their face, and you are just putting here in their face. Yeah, you are putting here in their lungs. Like, and you don't mask, and your goal is just pumping here into their lungs. What is going to happen to the secretion in their upper airway? You're going to further push it down into their lungs, like getting more distal into different part of their lungs. Does that make sense? Is that what we like to do as physio? No, we don't want that. We want those secretion outside. Imagine secretion in the upper airway, secretion in the the trachea, or maybe at the back of their throat, for instance. And we just pop in here, we just don't match for them, and 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 the mask and the here we are giving them the positive pressure now start pushing those secretions down back into their lungs. This is not what we want. We want those things to be cleared first before we get. And again, if somebody have got a whole lot of secretions in their upper airway everywhere, and we just done the NIV mask for them, do we think they're going to synchronize well with that machine? Do we think that machine will deliver the effective the effective treatment that we actually want that machine to do? The chance is very low, because now you've got secretions blocking everywhere. The VQ, there will be this VQ mismatching and everything. It's not going to work well. And patient might even struggle to synchronize with that machine. So what do you want to do with that device? What do you want to do? We are thinking about optimizing patient test and escalating to medical team, even if you can practically start them, adjust settings and everything. Yeah, good. You should be able to escalate and being able to pick up clinical signs that will say, yeah, this patient needs to go on this device, if that makes sense. All right. And again, but if it is on the other side of it, if you flip that to the other side, like they are wheezing because of their bronchospasm due to their or associated with their asthma, then in that regard, we might start thinking, physio. Even physio-wise, if I need to treat them, I need to take caution. We have said this several times, because most of your treatment adjuncts or most of the things you want to be doing with an asthmatic patient, if you are not careful, you can even worsen their condition, because they've got an irritable upper airway. They've got airway that if you further push here in or push here, you are just pushing here in and now you are just shifting here in the upper. That might also worsen their bronchospasm. You don't want that. You don't want to worsen the condition of your patient. All right. So we need that clinical reasoning, that judgment. We need to be able to make those judgments and say, yeah, they are wheezing. Why are they wheezing? Yeah, it might be because they've got mucus plug. Let's do chest clearance. Do they need bronchodilator? Yeah, speak to the doctor, speak to the nurse. You have hospitated them. Now you have to do the chest clearance. Now, again, we expect, yeah, if you do your chest clearance, you've gotten done on the bronchodilator, hypertrophion, salbutamol, whatever. So we expect that the wheezing sounds to start coming down. Then we can put them on NIV. Yeah, can we get more that opinion? What we can see at their bedside? Thank you, PT Chika, for that. Yeah, what other thing can we see? What other thing can we see in their bedside? It's really great if we participate. If you participate, the more you participate, the more I'll become more active. But if you leave it to me, I'll just be doing it and it's not going to flow. Yeah, we need participations. Yeah. I know we'll still come back to do some of these things again, because I know these are really, really new. I won't say extremely new, but we are not really getting those experience, those exposures in some of these things. And honestly speaking, we really need to start thinking about advancing some of these skills and seeing some of these patients. They need physio. They need physio. Some of them need physio. Yeah, especially those of us that are in specialist centers. And yeah. All right. What other thing can I see at the bedside that can make me think, oh, I need to do something to relieve my patient, their distress? What other thing I'm not going to see at their bedside? Who is helping us? Are we still here, please, guys? Are we still here?
We are here.
All right.
We are here. The SpO2 is going to be fluctuating, obviously, because he won't be saturating well the patient as a result of the situation.
Yeah, thank you very much. Absolutely. Yeah. If you look into their targets, if you look into their saturation at the bedside, you might find they might be hypoxemic at the moment. Their oxygen might be going down. They might not be maintaining target sat at the moment. Yeah, it could be something that we need to pick. Yeah, you see patients struggling. They are just distressed and everything. They are no likely. You go to their bedside. Yeah, the oxygen might start going down. Yeah. It could be an indication that, yeah, you might think they might even be at the moment, they might be on 60% as opposed to we all breathe with 21. They're all using 21. Somebody is now needing 60%. That's huge. 60% to breathe 90 when they are supposed to be 95, 97, 100%, or 60%, 40% to be breathing 87, 80 something. This is low. This is low for a patient that are meant to be on scale 1. So think about all of these things. So we might want to say, yeah, oh, I think I need the ABG. If I look at the ABG and I see that, oh my God, the pH is gone, the oxygen is gone, The CO2 is gone. What do? They need an IV. It might even just be oxygen alone. I might say, oh, the oxygen is gone, is way. This patient really needs something to relieve their breathing, to make them comfortable. Yeah, I might think about that. It could be a case of type 1. People can go on CPAP, type 2, BiPAP, all those kind of things. All right, let's see other thing people are breathing here. Yeah, fluctuating CO2, problem with saturation. Thank you very much. The machine will be less effective, reduce chest expansion. Yeah, if you go to patient bedside and you find that there is reduced chest expansion, maybe they are drowsy at the moment. Somebody is drowsy. They are not even opening their eye. They are, ideally, you go see a patient, they are not opening their eye, they are not doing anything. You should be thinking about what is going on. Why is it? Have you speak to the nursing staff? What have you done? Have you run ABG? Why are they this way? Because we don't know in our ward, we don't want patients that are unresponsive to be on the ward. They should be somewhere here. They should be on another ceiling of care. If they have full escalation, they should be somewhere else. So, and again, patient, like I mentioned, if patient is really, really very drowsy, it could be that now the CO2 is knocking down their respiratory, their respiratory center. So we really need to be careful and do something. We need to refast that. If we don't refast that, what can happen? Respiratory arrest, coma, they will die. So we need to refast that. So it could even be patient on maybe narcotics or the opioid medications or anything like that. So, and they are in load of medications. Maybe following their operations or procedure they've had, or they've had abdominal surgeries, or it could be hip replacement or whatever things now. Now we have overdosed them on pain medications. If you overdose them on pain medication, the patient can become drowsy. And what is the implication if they continue to become drowsy? You should relate that as physio. If they continue to become drowsy, what is going to happen to them? They will start struggling to ventilate, to breathe out, to wash out CO2. If they continue to retain CO2, it's going to be a problem. That CO2 will start driving their pH. And don't forget our body like pH to be between 7.35 to 7.45. If pH start going deranged, start going otherwise, what is going to happen? Your enzymes will not work well. Your body mechanism will start failing, which is not what we want for our patient. Thank you very much. Yeah. Slow capillary refill. Yeah, great. If you've got somebody, especially with oxygen issues, type 1 respiratory failure, you might start seeing cyanosis and all of those things. Yeah. Signs of signs showing hypoxemia, you can start seeing that. It could be that you start thinking, oh, does this patient need to go on another support to help them to offload their breathing? This is how we think. What that there are loads of things you can find at the bedside. So what other things are we thinking about? I'm really taking time on these things. I can really easily just rush through and go away, but those clinical reasonings are just why we are having this discussion. Let's build those clinical reasonings. The way we see patients. The way we see patients, like how do we see our patients? That is why we are here. All right. So what other things? How about fatigue? What happens to fatigue? Fatigue. You see patients, they are just tired. They are visibly, well, if patient is tired, you can relate. Like if somebody is really, really tired, they are visibly tired. They are visibly tired. You can see them. Or you can find somebody with, really, really very anxious or really they are just working hard. They are really working hard. You can even hear some audible, you can even hear it. You can hear it, you can feel it, you can see it. They're working hard. Their sternocleistomastoid, what do you call these things in the neck, scalene muscles, all those things have kicked in. Then what do? They need to go on support. We need something to offload their breathing, to make their breathing much more easy for them. That makes sense. So if you are the physio, you have been called to see this patient, they called you to come and see them from secretion point of view, or from chest optimization point of view, or from lung volume, or whatever thing they've called you to see. And you see patient in that position. What conversation do you want to have? Imagine this kind of patient. Now, brief physio things now. How do we manage them? Suppose you've gone to see patients now, they are really, really working hard and they've got secretion in their chest. And they are working hard, you can see it. All the accessory muscles are kicking, sternocleistomastoid, scalene, everything, trapezius, upper trap, everything is kicking now. So how do you help them to manage their secretion? Let's think about that. How do you help them to manage their secretions? How do you help them to optimize their chest? Let's think about that. Hello? Are we there? Yeah, let's see who have come through. Yeah, we are here. Thank you, thank you, thank you. Okay, so how do we help them? Because what is really important is how we see patients, how you see patients. That is what really matters. How do you see your patient? If you don't get that way, whatever you will be doing with them, you may not get those approaches, and you may not even be doing anything, and you may even worsen, you may even make them worse. So how do we see these patients? Imagine you are being called in the middle of the night, you work in UCH, or you work in whether university, blah, 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 or UCH, or teaching hospitals in Port Harcourt or Abuja or anywhere. So you have been called in the middle of the night to come and see a gentleman is really, really, really working hard. And the handover they've given to you on the phone is, yeah, this man is standing cracky and really, really working hard. So how do you see them? So how do you help them? I don't really want, like, just give me some physio approach. Like, this is what I would do with them. This is what I would do. Things like that. Just give me some basic things and we'll move forward. Yeah. Let's see what have come through. Yeah, some breathing techniques like percussion, vibration, segmental breathing. Okay, lovely, lovely. Good stuff. Good stuff. All right. So the thing is this. At the moment, we are at their bedside. They are really, really, really working hard. They are working hard. In fact, they are even struggling with attentions. They cannot give their attention because they are just focusing on their breathing. Baba, they cannot even talk in full. Their talk is breaking and everything. Do we think they will be able to do the SCBT or deep breathing exercises? Think about all of these things. Do you think those patients, yeah, it depends on the level of fatigue anyway, but imagine somebody that is really, really, really working hard. Do you think they will be able to synchronize or listen to instructions to be able to do, yeah, give me that nice deep, give me that long deep breath, taking deep breath. Do you think they will be able to do all of those things? It might be difficult. It might be difficult. We might be limited in some of those treatments. That is what I'm saying. We might be limited. Yeah, great. We can still go in and yeah. But again, think about it. Think about it. I'm still coming to some of those things we can do with some of these patients, first of all. But think about this thing, first of all. Like, how are we going to help them? Somebody that cannot even follow in clock, they cannot synchronize breathing. They don't even seem to be having control over their own breathing. Do we think active treatment might be appropriate for them at that moment? Start thinking about that. Because if you don't see those patients the way you should be seeing them, you might just go to the and say, Baba, taking deep breath through your nose. And Baba is not listening. Baba cannot even do that. They are just breathing through their APCs. At the moment, they are just and do you think they might be able to do those active treatments? That means at the moment, the active treatment might really be limited. That is what I'm trying to pass. Active treatment might really be limited. Like in terms of deep breathing, it might just be us being thinking about, yeah, what have I got in my toolbox to support them passively? This is how you should be thinking as physio. This is how we should be thinking as physio. If that makes sense. Let me see if some other things have come through. Let's see. Yeah, ventilators, yeah, people, yeah. So now the approach is this: you go to patient bedsides, they are not synchronizing, they are not, they are struggling to ventilate. You should start asking questions. What is their ceiling of care? What is their ceiling of care? Have they been reviewed by the medical team? What are their line of thinking? Now this patient is struggling, they don't even seem to have control over their own breathing. They cannot control it. So what are we thinking about? Do they need to go on NIV? They might be needing passive things to support them. This is the point I'm trying to raise. Your ACBT, your breathing exercise might not be 100% really, really very helpful for this patient. You might be limited. Think about that. It is not in every patient they call you to see that they can synchronize with those active treatment that you want to be doing for them. We might need to go that way around. We might need to think about, at the moment, what is the issue? Is anything bothering them? It could be me going to their bedside, that kind of patient, say, Baba, open your mouth, let me see if there's anything. I can just maybe do some yanka, see if we can trigger cough. See, and again, think about it. If I even need to look into my toolbox for my passive treatment, I need to think, wait, what passive treatment can I be doing for this patient? Will they synchronize? If I'm thinking of positive pressure, like I'm thinking of covaxin, for instance, I have to think my settings. I have to think about marrying my settings to their own comfort. If patient is doing epical breathing, now I need to think about settings that will match whatever their presentation is. I don't know if that makes sense. That will match their comfort, level of comfort. So we need to think about when it comes to our treatment ladder. Sometimes you might need to jump the ladder and start from the top. You might need to start from the top to bottom and walk your ladder down and walk down the ladder. And sometimes you might need to go from top you might need to go from the bottom of the ladder to the top. It is patient-led. That's what I'm trying to pass across. Patient treatment is patient-led and it is individualized to the patient. When I say treatment ladder, what I mean is you are going, ideally, we like to go from active treatment, passive treatment, or we like to go from non-invasive to invasive, but it's not always the case. Sometimes you might need to start from the top of the ladder and work your way down if you need to. And sometimes you go to the top of the ladder, some patient will just plateau. Yeah, you just have to continue to support them with your highest treatment too that you got in your box. I don't know if this thing is making sense. And sometimes some patients, it might just be good, but usually patients that are really, really poorly, you might need to start from the top. Either you stay at the top or you work your way down. This is how you think as physio. If patient is really, really very fatigued, I'm thinking top of my ladder, do I need to insert MP if there's no MPA, if there's no contraindication? Do I need to go do deep suctioning for them? Because I know they are fatigued, they are really, really very restless, they are distressed. If I ask them to cough, their cough is going to be weak. My ACBT will be useless, my deep breathing will be useless. Yeah, I need to also think about, at the moment, will they be able to tolerate my percussion shaking and all of those things? Will they tolerate that at the moment? I need to think about, I need to do deep suctioning. I need to do ACB, I need cough assist to augment their cough. This is why we need some of these treatment tools. Think about all of these things. Think about all of these things. And again, if I'm able to optimize their chest, then they can go on NIV or they can go on CPAP or whatever it is. And if they are not, and again, we need ABGs. Why I'm doing all these things, medical team are also optimizing them. Some of them might need antibiotics, some of them might need steroids, some of them might need pain optimization, pain medication. Some of them might be needing fluids. Some of them might be fluid for maybe to support their blood pressure or anything. Some of them might be needing diuretics, medications to wash out water from their body. So they are doing their bit, and I'm also doing my bit. And we are supporting the patient. We are communicating together. You are speaking to me, I'm speaking to you. This is what I'm doing. This is my plan. You're also telling me your plan and my plan, and we are working together. This is how things work. If that makes sense, get that right. Really important. All right, let's continue. Contraindication, I won't talk about this again. Why you don't want to use positive pressure.
Sorry, sir. Please, can I ask a question?
Yeah, go ahead.
Please, this one is about a pediatric patient. So he has cerebral palsy, referred for physiotherapy. But then, most times when he comes, he's breathing normally. But when you start your procedure, he will now cry. And when he cries, as if the breath, you will now see it for some time. He's struggling to breathe. So I don't know what we'll do for such a patient. Because sometimes he will have catarrh, then we'll tell the mother to do this the warm that's covering the body with a blanket, use some steam, hot steam and all that. But then the catarrh seems not to be going. And then when we even referred him back to the medical team, the pediatricians. So they now told the mother that it's part of his condition. So I don't know whether we should stop seeing this boy for physiotherapy, because each time he comes, he will cry. And when he cries, the breathing is, in fact, we'll even be afraid because of the way he's breathing.
Yeah, thank you very much. I love that question. And I think I love that kind of scenario working with pediatric patients. Do you know why? The reason is this. For peds, I used to tell people that anything you really want to do with pediatric patients, we need to think about getting it right due to a lot of reasons. Number one, think about physiological reserve. Unlike adults, I think in the past, when I was talking about bucket and do this thing, I spoke about that as well. They don't have all this bucket and do. They don't have anything to compensate for their reserve. They can get fatigue quickly, very, very quickly. So we need to think about, what are we doing? Let us reflect from our own side. What are we doing with this kid, with this baby that is making her to quickly fatigue? Let us reflect. Is it in terms of dosage of whatever we are doing? Is it in terms of intensity? Do we need to grade it? Do we need to come down on whatever we are doing? Do we need to try another skill set that you just optimize that once and for all and we'll stop? Because again, think about that. And again, I don't know what we are seeing now. Is it for respiratory optimization? Is it for functional point of view? I don't know. But if it is for respiratory, I would advise that anytime we like to see this lady, get like monitor ASAT, monitor everything, monitor a heart rate and everything. The reason is this: sometimes for respiratory patients, for respiratory pediatric patients, I normally tell everyone, like my colleague and everybody or anyone, that get your non-rebreathe at their bedside. Your non-rebreathe oxygen, get it at their bedside. You can just do small things for your peds, for ped patient, and they will just fatigue. And how do you know? Sometimes some they cannot communicate verbally. Yeah, you can know through clinical signs, you can know through their work of breathing, tracheal tugs, and all of those things. You can know through their saturation and everything. And before you know, the RT will just start dropping. Their what is it again? Their blood pressure or their heart rate may start misbehaving as well. What do you want to do? You don't have to be panic as physio. Just pop that non-rebreathe back on them. I think ideally, pediatric patients, they are likely to die of respiratory arrest. Unlike adult is likely for cardiac. Adult is more of cardiac than respiratory. But peds, they are more of respiratory than cardiac. There are reasons to that anyway. So now, what you would just want to do is they'll just de-recruit. Their lung will just de-recruit. Let's say you are doing respiratory treatment, they just de-recruit and their saturation will start dropping. What do you want to do? Just pop non-rebreathe on mask on them. Because if they are desaturating and we are not supporting them, we are not even monitoring their oxygen, we are not even monitoring our oxygen or whatever, and we are not paying attention, though we are looking at the work of breathing and everything, it could be that in that kid, it is the oxygen that is the issue. Let's just pop non-rebreathe. Non-rebreathe man will quickly refast our oxygen. And once the oxygen is refast, it's likely that the work of breathing will settle. So while we are doing on the work of breathing, like while we pop our on non-rebreathe mask, it could just be us now giving our time to rest and everything like that. And again, on the aspect of crying, it could be we using more of the parents, like mother, father, or play therapy, find what she likes, listen to. No, they cannot communicate. Sometimes it could just be we, getting some histories or getting some, what do you call it now? Getting some, what do you call it now? If you just, we talking to the mom, what does it really like? What does it really like? Like, do we need to change some of our approach? Do we need to decorate? Do we need, anything that will just make the, the treatment approach to be more really, playful to her and distract her or anything that will, yeah. But what I'm trying to pass across is ped patients, they can easily fatigue due to anything. So that's why we used to say, like, just get the treatment. For instance, now, if they, like, let's say they want to call you to peds to come and treat it, like you are the on-call physio tonight now. Let's say, for instance, you are the on-call physio tonight. I'm the pediatric physio. It is my responsibility to hand over everything for you. And when you come around, don't come and do over sabi. Like if you, generally speaking, their bedside, they will put the treatment plan. This is what we've been doing for this lady. Oh, do one suction, do this, do vest therapy, do this for this. PEP device, use it ×2. They will put everything there. Just go there and repeat whatever they are doing. Though things might change sometimes. Yeah, but think about doing whatever they've been doing because they know the ped physios that are working with that child, they know that, anytime if you do extra things or you do more than enough things, this girl is going to fatigue. And if it's fatigue, you may not gain anything. You might not even get anything out of her. So it could just be we weighing our options, weighing what we are doing with her, look at our own approach, look at, get it once, get it right once, do it once and leave her to rest. It could just be something like that. It could just be I don't know, maybe we are seeing that from outpatient level or in the hospital or something. If it is outpatient.
Yes, it's outpatient level. And it was when he was crying. So we were checking the SpO2. So while he starts crying, baseline SpO2 when he's calm is around 95 to 98%. He's around 2 years old child. So, but when he starts crying, the SpO2 starts dropping, even when we are not doing anything for him.
Yeah.
He will now cry, the SpO2 will drop up to 85. At the stage, it was around 85%. So it's just the crying that makes the SpO2 to drop.
Yeah. Okay. So it could just be we finding a way to I won't say we should stop seeing her. Of course, it is our job. It is just be we finding everything we can do to make the treatment therapy everything. It could be maybe she does not like to see some of our faces. It could be we teaching the mother what we are doing with her. Let the mother do those things for her. It could be something like that. And again, supporting her while we are doing our treatment. I don't know if we have access to like maybe those oxygen to support her to quickly support her oxygen and everything, all those things. So if we have
No,
access to those things,
we don't have access to that.
yeah, so that's so but I think the best way to go is teaching the mom some of like whatever we want to do, let the mom do it. Of course, it's also one of those things we need to be encouraging. Teach the mother how to do those physio. She should be like we need to get her to be doing those physio for her. Even while we are not there, even at home and everywhere, she should be doing regular physio with her. So I think it should just go with the mom and see. Have we tried that before?
Yes, but the mom doesn't do as well as she is taught. She will just do a little.
Yeah. I think we might just need to train the mom, like just train the mom, like get the mom to be doing it. Yeah. And sometimes it could just be maybe she doesn't like, because it happens in adults too as well. Maybe you don't just like your watch coat or anything and don't too scary for her or something. It could just be maybe mom doing those things, replicating those things at home or something like that, whatever we are doing for her. Yeah, it could maybe she likes to, we just have to find out. Just need to work to our comfort. Like, let's work out what is making this lady. What is the trigger? Is it our faces? If he does not like to see me, there's no reason for me to go. It could be, I love PT Joseph. Just PT Joseph to be seen now. If he likes the mom to be doing it, yeah, the mom. Yeah, I've been called a lot of time to see Pete. Even when sometimes I will just be there. It is the mom that I will just, yeah, let's do this one. The mom will do it perfectly. Now, if you now want to intervene and say, yeah, let me do it, you are not, yeah, some will say they will not be compliant. So it could be we just training the mom to administer.
Yes. Thank you very much, sir.
All right, thank you. All right. So let's continue for the contraindication. Like I mentioned, it's still the same thing, pneumothorax. Ensure that the upper airway is free. If they've got any tumor or anything obstructing the airway, you don't want to pump air into those lungs. You don't want to further push those things down into their lungs. We have explained these things. Yeah, GCS, of course, GCS less than 8 might mean that somebody is struggling to protect their airway. If they are for full escalation, they might need to go straight away to bypass NIV and go straight away to invasive ventilation. Or if they are not for full escalation, then we might start thinking about palliation. So it could be. So all of those things. If somebody have got recent surgeries, ENT surgeries, oesophageectomy, or whatever things, before we commence them, we like to be speaking with people that did those surgeries, like the surgeons. Oh, are you happy? Because we know we want to be pushing here. Like we want to be pushing here into patient lungs. Here can leak out. Here can disrupt the anastomosis of that region, that incision. So we want to be speaking with those surgeons before we commence on all of these things. The patient is vomiting as well. Ear can leak into their airway or into their stomach. They can vomit. They can also aspirate on their own vomit, which we don't want. If they aspirate, like they aspirate content into their lungs, that is another problem. We don't want that. So we want to take caution with all of those things. So people are having cardiovascular instability, hemodynamic instability. We also want to be careful. Like I mentioned last time, all these things are not white and black. There's no white and black in patient care. There are no white and black. It all depends on, let's look at the patient. Let's look at their patient presentations. What have we got in our toolbox? As physio, you look at your toolbox. What have we got to support this patient? From the medical perspective, they look at our toolbox. Then we both sit down, look at the patient and say, let's decide risk versus benefit. Let's pop them on these things. Let's support them. All those kind of things. So that's it. So now What is this one? So, sorry, let's go this way. Oh, it's appeared. So yeah, this NIV decision at the bedside. I think we've spoken about this already. Look into their work of breathing, look into some of their anxious, their respiratory rates, all those things you are picking at their bedside. You're also looking at ABGs. You are looking at their ABGs as well, and their chest X-ray. Before we commence somebody an NIV, we want to look at their ABG. What is the ABG reading? What is the position of CO2 and pH? What is the oxygen saying? And we also want to look at their chest X-ray. Why are we looking at chest X-ray? Somebody, before we start somebody, and I think from the discussion now so far, yeah, I think we should be able to answer that. Why do we want to start somebody on, okay, why do we have to check patient chest X-ray before we commence them on NIV? Yeah, who is helping us with that? I think from the previous conversations, you can relate that. So why? Because we like to see. Yeah, we like to see patient chest X-ray. Why do we have to see patient chest X-ray before we start them on NIV? Why? What is the reason for that? What do we think? What do we think? Because if all these things doesn't make sense to us, it might be difficult sometimes to speak with the doctor. To say, yeah, because they're going to ask you questions, not question testing your knowledge or something. It's just like we are conversing now. We are both listening together. So if you don't have the requirement, like if you don't have the knowledge base, you might just be like, then why have I gone to speak with this person? Is this person testing me? No, whereas it's not like that. Ideally, it shouldn't be like we are talking on the normal ground. It shouldn't be like that. So it is expected of us to have good knowledge based. So that if I'm the doctor, you are coming to meet me. Yeah, we both converse. Yeah, I think this. Have they have this? Have they have that? Yeah. We are good to go. Let's start them. Let's commence them. Yeah. What is the pressure protocol? We are starting them. What is the yeah? And we both start. So why do we have to see their chest X-ray before we start them on NIV? What do we think? What do we think? Who is helping us? Are we still there? Hello?
Yes, we are there.
All right, thank you. So what do we think? Don't worry, we'll still come back again, talk about like this thing again over and over, even ventilator, mechanical ventilator, we'll still talk about this more. Let's just see what we can gain in all of these things for now, and because we need to build on all of this knowledge. So why do we have to check people's chest X-ray before we commence them on NIV? What is the reason? Anyone, any idea? You don't have to be right or wrong. Just pop idea in the chat. Yeah, anything. Yeah. Why? Right. The reason for that is, remember what we said last time, pneumothorax. Pneumothorax, big one when it comes to positive pressure. Big one. We all like to check their chest X-ray first of all to see, yeah, there is no pneumothorax. They've not got any pneumothorax. Why are we being concerned about that? The reason being that we know that if they've got pneumothorax, they've not got any chest strains, and we put them on positive pressure, hear my leak, and go into their pleural cavity and worsen that. We can give them tension pneumothorax. We don't want to go into that lane. It's medical emergency. We don't like it. We don't want to worsen our patient condition. Basic things, if that makes sense. And again, you can look at chest X-ray and you find some small pneumothorax or something. If patient will be going on NIV, then it has to be joint decision made by the medical team. If they're happy, sometimes they might say, yeah, they were happy, pneumothorax is inconsequent, risk versus benefit, let's do it. Yeah, fine. But you're looking at patient chest X-ray, you find pneumothorax, you want to take caution. It's a caution. If I do it, yeah, things might go other way around. We don't want that for our patient. If that makes, and again, while you are checking that, what tests are you checking? Physio-wise now. General decisions. I'm speaking with the doctor now. Yeah, let's check that. They've got to start them. Yeah, no. They are not appropriate because they've got this. So let me see. It might be you speaking to the young doctor that will say, yeah, let me speak with my consultant first and I'll get back to you. Yeah, might be something like that. But now, beyond that, from your own job now, your own duty now, it could also be you looking at the chest X-ray. What have they got? Oh, have they got have they got consolidation here? Have they got harshness or opacity at the right side of the lungs or left side of the lungs? Yeah, they need some chest clearance before they go on NIV. Remember what I said earlier. You're also looking at their chest and find out, yeah, any physio indication they've got lung volume collapse here, white out on this side. Yeah, I need to do something, because we know that if you pop them on the chest X-ray, if you don't optimize their chest, what that can do again is you can further push down those secretions into distal alveoli that will really, really make it difficult again for your patient to clear them out of their lungs. And again, from synchronization point of view, patient might also struggle to synchronize with the machine. So let's optimize their chest, if that makes sense. So you are looking at the chest X-ray. If you've got the competency or you are speaking with the medical team, you can gently decide, yeah, let's start them on NIV. And again, you can also look on the other side and say, yeah, this is my physio job. I need to do these things. I need to see. And again, if you need to optimize their chest, think about, what do I need to do? This man is fatigued. He's even drowsy. Can they cough? Can they do ACBT kind of things? With ACBT going to be my top priority at that moment? No, the answer is no. I need the top of my skills. I might need to go top bottom with my treatment to support them, if that makes sense. Let's continue. Yeah, let's get to the business, BiPAP and CPAP now. Ideally, some people will say NIV is BiPAP. It's just nomenclature kind of thing. Some people say NIV is BiPAP and CPAP, whatever it is. Get the clinical reasoning behind it. That is what matters. Yeah. So when you say BiPAP now, BiPAP is somebody breathing between two levels. If you look at this picture here, patient is breathing between, look at this graph. They are breathing between two levels. There is a pressure. We are giving them two pressure. If it is BiPAP from the name, bi means two. You can also find bilevel, you can find biphasia, you can find, these are just nomenclature kind of things. So patient is breathing at two levels, low level pressure and high level pressure. Now, the low level pressure is the EPAP. So this EPAP is the pressure that stays in their lungs. Don't forget, we've got two breathing cycles, inspiration and expiration. So EPAP stays in patient lungs, either during inspiration or during expiration. This pressure is always in their lungs. This pressure is always in their lungs. The pressure that is always in their lungs, I'm trying to simplify these things. The pressure that is always in patient's lungs is called end positive expiratory pressure. And what does this pressure do? Now, see this pressure. Let me bring in two more terminologies here to make it, please. Are we here, please? I want to really ensure we get this thing once and for all. Hello, are we here?
We are here.
Okay, all right. So thank you.
Yes, we are here.
All right, thank you. Thank you very much. So now, when we talk about EPAP, pressure that is always present in patients' lungs every time they are breathing. The only time you will not find this pressure is when they stop breathing, which is a bad thing. It could be that they died or something. That's the other part of it. But this pressure is always in their lungs. What does this thing, what does it do? What it does is just to keep the airway open every time. It keeps the airway open. It makes the airway to keep opening. We don't want it to collapse. It keeps the airway open every time. What do you call that pressure? EPAP. Some people can also call it PEEP. PEEP, like PEEP. PEEP, positive end expiratory pressure. Now, PEEP and EPAP, they are the same thing. Now, CPAP, I'm bringing in another thing now. CPAP is also the same thing with EPAP, and it's also the same thing as, please get this thing. Sometimes this thing can be really, really very confusing, terminologies and these things. Now, CPAP, this CPAP, you can see here, CPAP means continuous positive expiratory. Look at the name, continuous. Continuous, look at the graph. Look at the graph. You can see it's just pew. It's always in patient's lungs. So CPAP and EPAP and CPAP, EPAP, and PEEP, they are all the same thing. And what do? This is the pressure that is always in patient's lungs every time they are breathing. And what this pressure does is just to keep their airway open. In fact, in the language of in physiology language, they would say to splint open their airway, to splint open their airway, to keep their airway open. And what does that mean? There's another concept I'm bringing in now, which is functional residual capacity. Functional residual. Look, this CPAP, KPAP, or PEEP, what they all do is that functional residual capacity. All they do is functional residual capacity. What is the meaning of functional residual capacity? Functional residual capacity is, look, if I'm blowing a balloon, for instance, you know, at the start of the balloon, it might be slightly like maybe tougher for me, something like that. Like I have to put in a bit of more effort. Then after that, on top of like my initial effort, on top of that, my initial effort, everything becomes more easy for me. Now, those initial pressure, like the initial pressure for me, if I need to inflate balloon now, I need to inflate a ball or anything now. Yeah, those initial pressure that I need, that initial effort I need to push in to bring everything out, to inflate that ball or balloon or whatever now, that pressure is called functional residual. I don't know if that makes sense. Another analogy, if you remove somebody's lungs, God forbid you remove somebody's lungs and you put it on the table, or you put it in the water, you put it on top of, like you put it, if you put a water in the bucket and you put somebody's lungs in it, it's gonna float. Why? Because there is a air in the lungs that will never leave that lungs. These are functional residual capacity. So what we are saying, the functional residual capacity, your PEEP, your CPAP, your HEPAP, these are pressure that keep the air open. So that every time patient is breathing, have to think about this thing makes sense. So that every time your patient is breathing, we don't want to do forcefully open their airway. So we want the airway to be open already, so that when they do, like, let's say their first breathing, we splint open, we open it. Second breathing, you are just adding on top of the initial one. It's just like if you are blowing a bottle now, you are blowing a balloon. The first effort might be slightly difficult. After that first effort, other ones you are just adding on top of it, on top of it, on top of it. So that is why it's really very important for the patient airway to be open. Now, I quickly ask a question. If you have this pressure, do you think this pressure will be supporting patient oxygen, or is going to be supporting patient CO2? Can somebody quickly answer that? Just jump in the box and just drop your answer. Do you think that pressure will be supporting patient oxygen, or is going to be supporting patient CO2? What do we think? Quickly, because of time. What do you think? From that explanation, if you are followed through, what do you think? The pressure is keeping your airway open every time you are breathing. Will that pressure be supporting patient oxygenation, or they will be supporting CO2 removal or something? What do you think? What do you think? Yeah, let me see some answers have come through quickly. Yeah. Oh, these are the previous ones. Yeah. All right. So what do we think? What will this pressure be doing? Will they be supporting patient oxygenation, or will they be, what do we think? You could quickly just drop something. Anyone? Anyone? Are we still here? Hello?
Yeah, here, sir.
All right, Ma, thank you. So what do we think? What do we think? Okay, I answered. So it's going to be supporting patient oxygenations. So when some answers are now coming through. Thank you. Yeah, supporting oxygen, supporting CO2 removal. Yeah. Thank you. Some answers are coming through. Really, yeah, good. Thank you. So now they will be supporting patient oxygenations, because these pressure are always in patient alveoli. So they will be supporting patient oxygenation, if that makes sense to somebody. So on the ventilator now, you can find parameter that will say PEEP. When you see PEEP, you know that people are what that PEEP is saying. Yeah, that PEEP is always there in patient's lungs, so that patient lungs will not collapse. Yeah, that's what it does. So sometimes, if let's say ventilator now, for instance, I want to increase patient oxygenation, I may go high up a bit if there is reason for me to go up on their PEEP. Same thing here on NIV or CPAP or BiPAP, whatever now. Okay, if I need to top, let's say my patient is now desaturating, they are not meeting their target SAT. I can go high up on their EPAP. I can go up on their CPAP, if that makes sense to somebody. That is how it works. Now, there is another pressure. So that's low level pressure, pressure sitting in their lungs, sitting in their alveoli. That's EPAP, CPAP, PEEP, or whatever now. FRC, those are pressure sitting in their lungs. Now you can relate those terminology now. Now, on top of that, there is a pressure at the top. At the top, that pressure is called IPAP, inspiratory positive airway pressure. Now, what is that pressure? Now, from the explanation we've been making so far, you can relate that patient that will go on NIV, they need to be able to maintain their own airway patterns. Their airway will still be patent. They can still breathe, even though their breathing is difficult, but they can still breathe. Now, if this patient, they are still doing inspiration, expiration. If this patient do inspirations, we need a pressure. Don't forget, most of these patients will be doing apical breathing. Like, it's just very fast and rapid breathing because of the work of breathing they are undergoing at the moment. So now, if they do apical breathing, we want something that will support that they are here, they are taking in, that their inspiratory breath, that will support that inspiratory breath, that will push that here down into their lungs. I don't know if this thing is making sense. Your patient is doing apical breathing, for instance. I'm just trying to simplify these things. Patient is doing apical breathing at the moment. We need something that will make that here to go down, to sink down into their lungs. What is that pressure? So we can support. What this machine is doing is, aside from you have said EPAP, pressure that will provide oxygen in the alveoli, this machine will also give your patient pressure support. That is the language we call it, pressure support, PS, pressure support. So anytime they do inspiration, this pressure support will support them to push air down into their lungs, to sink down into their lungs. That is pressure support, PS. Now, so which means anytime your patient do inspiration, pressure support will support it and push it down. EPAP will also do his own bit of it. So your patient is now doing EPAP plus pressure support. So EPAP plus pressure support is this. What is this? Inspiratory positive airway pressure. Let me explain this thing again. If I get the machine now, I want to start patient on the machine, on the device. I'm going to set EPAP. You know where EPAP is sitting, the pressure that will sit in their lungs. I will also set peak pressure, like inspiratory pressure. The highest inspiratory pressure I want them to achieve. I might say 20, for instance. I might say 15, for instance. 20, 25, 22, for instance. I'll put that up. Okay? Now, the difference between IPAP and EPAP is the pressure support. Does this thing make sense to somebody? Can I get a response? Does it make sense to somebody? It's just getting the theoretical background. Does it make sense, please? Does it make sense? Yeah. Does it make sense? Can I get a response, please? Hello?
Sorry, if you can explain it again.
Okay.
Hello.
All right, I will do that. Let me explain again. If I'm setting this machine now, hey kids, if I'm setting this machine now, okay, if I'm setting this now, so I'm going to set a pressure that will sit in their lungs, that will always be in their lungs. That pressure is called EPAP, which some people can call CPAP, which some people can call PEEP or mechanical ventilator, because this mode can also be on ventilator. That's why I'm just combining everything together. Now, I also want, don't forget, I want two pressure. I want one pressure is already in their lungs. But I know that they are struggling to ventilate. They are struggling. Their respiratory pump is failing. They are just doing apical breathing. Their breathing is not sinking. The air they are taking in is not sinking into their lungs. Let me use that jargon. Let me use that English. The air they are taking in is not sinking into their lungs. I want to give them something that will make that their air to be sinking better into their lungs. So the air that will be pushing, your patient is taking in deep breath now. They are taking in here through the nose. So the pressure that will support that hair they have taken in, so that hair can sink into the lungs, that pressure is called pressure support. If that makes sense. So now the pressure in their lungs plus the pressure support, two of them together will make the IPAP. If you had two of them together, it will make the IPAP. Which means, again, mathematics now. If I subtract IPAP and EPAP, it's going to give me my pressure support. Which means, let's say, for instance, now I'm doing the device now. I set EPAP to be 4. Please, let's follow. I've set EPAP to be 4, the low pressure now, the low pressure to be 4. And I set my IPAP to be, let's say, 20. So what is the pressure support? That will be 20 minus 4. So the pressure support is going to be what? So that is it. Do you understand? So the pressure support is going to be 16. So that means every time my patient taking deep breath, so that will be that pressure support 16 that will further push air into the patient's lungs. If that makes sense. So that is that about that. So now the other part that you can find is CPAP. That means if my patient is struggling with oxygenation, I will just use CPAP for them. CPAP. Let's say oxygenation. They don't. You look at their ABG. They are just struggling with oxygenation. Every other thing is fine. CO2 is fine. Their CO2 is not shifting the pH. It's not oxygenation. We are going higher on their oxygen. They are struggling. They are getting fatigued. They are getting tired. We will just pop them on CPAP. If that makes sense. If I look into the ABG now, and I find out that CO2 is shifting the pH and the oxygen is going low, I need two levels now, two things. I need two things now because it's two problems they have. I need a problem that will support their oxygenation, and I need a problem that will wash out their CO2. So we have known what is going to support their oxygenation, which is their EPAP. So what is going to wash out their CO2 now? It's going to be the IPAP. It's going to be the IPAP. It's going to be the IPAP that wash out their CO2. So what that means is the IPAP that actually controls the patient tidal volume. The way they are controlling their CO2 and everything. It's going to be the IPAP. I'll move forward. The other thing, why I put the other thing here is to correlate with the cough assist. Cough assist pressure, the wave on the cough assist is quite different. Because cough assist has negative pressure. Don't forget, we breathe in positive pressure. Cough assist is going to cycle into a subluxation phase, which is negative pressure. That is why you are seeing the graph about that. So I don't have to explain this. This is what I've explained. Patient, but for bilevel device or BiPAP, patient is breathing between two levels. They are breathing between EPAP and they are breathing in IPAP. So the difference between the EPAP and IPAP is the pressure support. So now, before we initiate NIV with patients, because of time, before we initiate NIV with patients, we want to really be very clear. What if we need to be asking ourselves? These are conversations we want to be having with the medical team. What if this NIV fail? What is the plan? Where are we going? Because it is not in every patient that we support. We are trying to push in here into their lungs. We are trying to wash out CO2. We are trying to do oxygenation for them and all those things. This adjunct will be supportive for them. What if this adjunct fails? Where are we going to go? We need to have that conversation before we start them. So now there are two things. Two things are involved. Some people, they might say, yeah, no significant, they are not frail, they are anything. If the NIV fail, straight into ITU, intubate them, give them breathing tube. And again, if NIV does not fail, good for them. We don't have to go into intubation. We don't have to intubate them because we know intubation on its own is costly. It's going to cost the patient family. It's going to cost we need some extra skill set to support them. And again, while they are being intubated, they might be on medication like steroid sometimes we might even need to medically induce some people. Sometimes some people might need to be sedated. Sometimes some people might need to be on paralytic agent that will weaken them and everything. We know all these things. So if we can support patient with NIV, there is no need going for invasive ventilation. But if NIV failed, two things. It's either they go to ITU for breathing tube, or it's either they go on palliations. If NIV is their ceiling of care, not all patients can go into ITU. These are decision medical team we make before they say, yeah, let's get patients to ITU. Not all patients will end up in the ITU. Not all patients. If a patient is really very frail, if you just give them sedative agent, they might not even wake up. They will just jump from that your sedation and go on to the other side of the ward. Not all patients can recover from those strong medications. Not all patients. So for some patients, it might just be, NIV is their ceiling of care. If NIV failed, palliation. And again, we also need to, before we start patient, have we optimized them medically? They need fluid. Have we given them fluid? Have the medical team, have they done that? Some people have fluid, they are just fluid loaded everywhere. Maybe because they've got heart failure or anything. Have they had diuretics? Some people are having a lot of secretions in their chest. Have the physio seen them? You can see why you are very important. Nobody can help them. You need physio skills to get those things out of their chest. So have the physio seen them? We need to think about all of these things. So it's really, really important. So again, I have explained some of these things. Before we start NIV, we need chest X-ray, we need ABJ. I've explained the important. We need medical optimization, physio optimizations. We need to discuss ceiling of care. We have to explain all of these things. And in terms of the machine, it can be really, really, really very, very, people can really be, let me say, really very anxious to have the mask. Just look at the mask. Somebody is struggling to breathe and you want to come, in their head, they will be like, oh, I need here, I need there. Some people can be ear hunger at the moment. So you now want to go to their best and just plug the mask in their face. They'll be like, are you trying to suffocate me to even hurt my problem? So we need to think about how we can gradually translate our patient to be able to tolerate all of these facts. Because ideally, that is why I say always understand patient. Like patient, look at the patient, get some reasoning right, first of all. So what do you want to do? Gradually translate them. Oh, get them to feel like you have set up. I will not talk about the settings because of they are practically on some kind of things. So if you are, so get them to, now we have set up the machine. Before you don the mask, the strap and everything, get them to feel it first of all. Explain to them what you are trying to do. Explain to them. Let them understand. And some people can be naturally be claustrophobic. So do we have any other thing we can mask or something we can use? Or do we need family member to give reassurance? Don't shout on people. People that are respiratory distress. They are, even if you are shouting on them, you are this thing, you will be adding more to their problem. Because anxiety can also make the respiratory rate to be high. That is why we keep saying compassionate care. Compassionate care. Healthcare professionals should be the lovely set of people in the world. Not shouting at this one, shouting. We need family members. We need even sometimes if we don't need family member to be, which I don't necessarily think it should be. Yeah, but we don't want our world to be clouded with people and all of those things. But yeah, when they come around, even if you don't want people, there should be a way we say things to people, not shouting at people, disrespecting people anyhow. No, they are already distressed because of their loved one that is on bed. So we need compassionate care. So get your patient to feel the mask. They can feel it at the back of their hand. They can feel it in their face, first of all. Because if you just don't the mask in their face and just trap them, some people, you are trying to help them. We know you are trying to help them. But at the same time, some people can really be very, very anxious. And if they don't synchronize with the breathing, with the settings and everything, they will not get best use of this equipment. And you might not be helping them. Anxiety might make things worse for them. People might, and because if here is leaking or something, we want, for instance, now let's say we set the IPAP. You people know what IPAP means now. We set IPAP to be 20 now, and your patient is not, and the EPAP to be, let's say 4, and the pressure support to be pushing here down is to be 16, and your patient is just getting 8 when it's supposed to be 60. It's not going to get good tidal volume. It's not going to help. It's not going to wash out the CO2 that we want the device to be doing. It's not going to. So if the hair is leaking, so we want the mask to be perfectly done, like it should be well placed. And on the machine as well, there is a part where you have to be checking the leakage and everything. It's really very important. So get your patient to feel those things first. Explain it to them. Explain if they have their loved ones around. Bring them in. Explain to them. Let them feel it. People should be part of our treatment. There is no passive. What I've moved away from passive treatment is you just doing everything, thinking for your people. No, it should be joint decision. Let's do this, and this is why I'm doing this. It should be joint decision. And again, through the NIV again, we can be doing everything at once. Physio, and again, after the NIV, before the NIV, between the NIV, physios, you are doing your job. You are optimizing their chest. If they need oxygen, you are supporting their oxygen. If they need nerves, they're having the nerves. If they need to be humidified, the humidification can also be added to the machine as well. These things have been done. I will not go in details of those ones. And again, we need to think about the mask that we perfect to add. How do we, that's another competency, another thing, but I will not talk about that here. How do you measure your patient for the appropriate mask? These are what we need to know again. How do you do the measurement? These are practical things. How do you do the measurement? Because if the mask is not fitting properly, like I mentioned, here will be leaking. If here is leaking, that might even be the problem. And sometimes you can even get the measurement right, and here is still leaking. It might just be you going to their best and look at their tidal volume. Why are they not getting? Because if they are not having good tidal volume, they might not be washing out good CO2. It might just be you going there and just adjusting their mask, or you swapping their mask to another one. They are fine. Everybody is happy. Patient, doctors are happy. You are happy. Patient, family, everyone is happy. All right. There are different face masks. I won't talk about that. I won't talk about the settings. I'll just jump in, but I'll put it in the slide so that we can go through it. And and again, how do we measure? I'll leave this. How do we measure? I'll just talk about because of I wanted to ask before. So how do you measure if NIV is effective? This might be hospital, maybe guidance or where you work or something like that. But generally speaking, we want patients to be on it as much as possible, maybe for the first 24 hours. So if we've commend patients on NIV, we want to be checking their ABGs, see where they are on the ABGs, what is happening with the CO2. Are they washing out CO2? Are they washing out, is that CO2 correcting the pH now? As it started correcting pH, what is their oxygen? We are checking those things. We can ask the nurse to do, or the medical team to run ABG 30 minutes, 60 minutes, or 1 hour after they've started, depending on where you work, after they've started them on NIV. And again, we monitor, at least for the first 4 hours, see where they are. If they are not improving, after first 4 hours, we can decide. Because imagine if the pH is less than, maybe pH is now going 7.25, the NIV is not doing the business. Oh, that pH is shifting too much. They might be tripping into a very, very severe acidosis that might be really, really very difficult to reverse. So we might be thinking about, intubation. We stop the NIV, we intubate them if they are for full care, ceiling of care. And if the NIV is not working, it might be, And again, it might, even before you start thinking, maybe within that 4 hours, you are thinking, what is going on? You think about, can we track the settings? Let's look at the settings. What do we need to change? What do we need to adjust? All those kind of things. And there are reasons why you should be adjusting some of these. Are competency machine-based. Play with the machine. Be aware of all these things. And I won't talk about that here, but just understand some basic things. You might be called to see patient on NIV. What I would advise is look at the machine first of all. The machine you are using, you've got in your facility. At least go online, go and check. Even if you don't have the competencies to change values and everything, look at their ABG correctly. What is happening? CO2 is not normalized. You can call the nurse. Is that something your doctor that have got competencies to do it? That's something we can adjust. The CO2 is not coming down. What do we think? Go have this conversation with them. And again, it could be that their chest, they've got issue with secretions in their chest. Because if they've got issue with the secretion in their chest as well, that is where physio comes in. If they got issue with secretion in their chest, the ventilator will not work well. Your patient might not synchronize well with the ventilator. The air might not sync well. That pressure support might not sync well. So it might affect the way they are washing out that CO2. But if you help them to clear the secretion in their chest, there'll be space, good VQ matching, and everything will be fine. So think about all of these things. So I will not talk about, like I mentioned, common reason why you find NIV failing. It could be you are not getting the setting right. It could be maybe something ears are leaking. It could be patient not synchronizing with the ventilator due to every reasons I have explained. It could maybe patient is really, really very agitated, they are distressed, they are confused. You can find confused patient just pulling out the mask and everything. It could be because of those. What can we do to support that? Think about all of these things. But confusion could also be maybe a caution sometimes. So before we even start them on NIV, it could be caution sometimes. So all right. NIV for end of life as well, like I mentioned initially, it can be used for symptom relief. not to prolong their life. NIV is not going to prolong their life. Of course, for patient for active treatment, if it is for active treatment, we can say, yeah, because the medical, they are still optimizing them medically, physios is still doing the active treatment. So in that regard, we can say it can prolong their life. But for end of life, treatment is always towards comfort. Active medical treatment might have been withdrawn. Active physio treatment might have been withdrawn. So we can say NIV might not really be like, it's not, of course, it's not going to be curative for them. So it might just be for symptoms relief, to manage their work of breathing, their anxiety, their shortness of breath. Some people might be needing the NIV overnight. Yeah, some people might maybe go on it during the day. They're having headache, they are retaining CO2, all those kind of things. So that is that about that. So we just take this clinical case study discussion and we go. Yeah. Hello, are we still there? Hello?
We are here, sir.
All right, thank you. So let's take this case study. You've got a 70-year-old lady. She's got CAP, community acquired pneumonia. Thank you for that. We've got community acquired pneumonia, the past medical history of bronchiectasis. She's got kyphoscoliosis. She's got RA, type 1 diabetes. She's got total knee replacement 3 years ago. On admission, she's breathless and fatigued. So despite the medical management, and her O2, so despite the medical management, I think she continues to deteriorate. That is a kind of this thing there. So, and the patient is for full escalation. Let me take the question again. You've got a gentleman, you've got a 70-year-old lady, she's got community acquired pneumonia, she's got bronchiectasis, kyphoscoliosis, type 1 diabetes, RA, total knee replacement 3 years ago. At the moment, she's breathless, she's fatigued. They've done medical team, they've tried to optimize her medically, but she's still struggling with her oxygen and she's deteriorating. And the patient is for full escalation. From my conversation so far, you know what full escalation is. Like, she can go on into the ITU, intubated and sedated and everything. So what are your assessment and your treatment? Let's think about this. This is you now, physio now. You have been called to see this lady now. So how do you manage this lady? Medical team, they are trying their bit. They are giving out pain medications, blah blah blah, doing everything they can within their bit. But this patient is still struggling with oxygen. They are doing oxygen therapy. She's still struggling and she's deteriorating. How will you assess this lady and treat this lady? What do we think? I'd like to hear us speaking here. There is no right, no wrong, just your clinical reasoning, what you think. How do you see this lady? So how do you see this lady now? Anything you can relate, just look at the question. Is there anything you can pick from my explanation so far? Is there anything you can pick from the past medical history that really makes sense to you? Is there anything that might say, yeah, this is how they are presenting that you are looking at? Just pick anything, random thing. So because honestly, the best way to be a good clinician is just case study, build that clinical reasoning. So that when you go second day, you go to the bedside, you are looking at different things. Yeah, oh, I need to check up, oh, I need to check blood, oh, I need to speak with the doctor first, oh, I need to do this. The way you see your patient is going to guide you on what you'll be doing with them. So now, how are we seeing this lady now? What do we think? How do we see her? We should run away. Should we run away and tell them? And yeah, if you are running away, if you are telling, is there anything that will inform you to run away from here? There should be reason. You are being paid to do your job. You are being paid for these things, either small or big. You are being paid for these things. If you are running away, I mean, is if you are not going to see this patient, there should be something that will inform you that, yeah, there should be clinical reasoning to back that claim. So that tomorrow, if somebody go to court and say, yeah, this patient need to see physio, they did not receive physio. You should have clinical reasoning and document why you are not seeing them and let the medical know team and advise appropriately. And all those things should go into your medical. And if you are seeing them, what will you be doing with this lady? Anything, just talk about anything that you can bring together. Hello? Who is helping us? We've got lovely physios on the call, so please, who is helping us? It's really important. It's not about me coming, blah, 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 do everything I know. Let's have moment to, Hello?
Please, what is THR?
Yeah, total hip replacement.
Okay.
Sorry about that. Physio is really, acute hospital is really very, like, it's a mix of medical knowledge, a mix of not really medical, but knowing like certain things, flags, caution, what to be interacting with the medical team, know your physio job, and yeah. So who is helping us? Time is running. Yeah, we need to, please, let's talk. This is a lady. Yeah, suppose I'm the doctor now, and I say, yeah, is that Uncle Physio? I call you in the middle of the night, and yeah, say, yeah, Physio, I've got 70-year-old lady, they are admitted with community acquired pneumonia. Yeah, they admitted yesterday. They've got background bronchiectasis, skyphoscoliosis, rheumatoid arthritis, type 1 diabetes. They've got right total hip replacement 3 years ago. She's now really very breathless and fatigued. We've been trying to give them oxygen, place them on antibiotics and fluid and everything. They just told you every medical thing they've been doing. So what other question will you be asking them on the call? Let's say you are at home now, somebody just called you. What other questions will you be asking them? Or you are at their bedside, or you are reading their notes, or you are looking at the patient. What are your reasons? Anything, just anything. Because we really have to keep building the way we see people, the way we see patients, the way we see patients, especially people that are poorly, people that are sick, at any level in the hospital, ward-based level, level 2 care, people that might be needing NIV, in the HDU or whatever, depending on the nomenclature you are using in your hospital, or people at the highest ceiling of care in the hospital, like the ITU or what do you call them, ICU or anywhere. So how we see them, first of all, is important. Like if you are reading the caseload, what are you paying attention to? Who is helping us? Please, physios, please help us. Okay, thank you very much. Some answers are coming through. Great. Let me check. I would like to, yeah, let me go up. Yeah, a lot of answers are coming through. I think it will be supporting their CO2 removal. That's PT Physent. I will support patient oxygenation. Okay. I will access our airway. That's PT Aisha. I will assess the airway, coughing techniques, breathing pattern. Yeah, she's going to do a to E assessment. Lovely. Absolutely brilliant. Yeah. PT Hamad. Yeah, I would like to assess the respiratory rate, the SpO2, chest excursion, auscultation, cough effectiveness. Yeah, great, perfect. Brilliant. PT Aisha again, I also look into their positions, positioning tolerance, pressure area. Lovely, good stuff. Yeah. PT Emilia, I will look into their respiratory rates. Yeah, assess their respiratory, auscultate them, look into ABG, SpO2, sugar level. Absolutely brilliant. Petit I will assess their A to E respiratory assessment. Lovely stuff. Yeah, great. I would like you guys to just put A, what are you checking in here? Maybe brief, because of time. A, this is what I'm checking. B, this is what I'm doing. Yeah. C, this is what I'm looking at. Maybe D, this is what I'm looking at. Yeah, that systematic kind of thing. Just do, yeah. A lot of answers are coming through now, which are really very great. Yeah, PT Modi, I will ask for our ABG result. Perfect. Assess our respiratory rate, 100%. Thank you for that. Yeah. Can we have few more? What are we? Yeah, few more. So yeah. So now, if you now look into the past medical histories from the discussion so far, look at the past medical history and look at patient presentations. Can you, what does it mean? What does it really mean to us? Look at the patient past medical history and look at the new presentations now. What does it really mean to us? I'm just trying to, we need to build that clinical reasoning. Look at the patient past medical history and look at the presentation. Like, what does it mean to us? What does it mean to us? There's a reason why I'm the doctor. Now, there's a reason why, even though I might not know you are the physio, I'm just the doctor. Like, suppose I'm a physio anyway, but suppose I'm the doctor now, I'm just calling you here. There's a reason why you will ask me what is the patient part on the call. If I'm calling you to come and see patient, there's a reason why you will ask me. If I'm the doctor, there will be a reason. There's a reason why normally you as physio, you will ask, now, what are the patient past medicals? What are their background? What are their comorbidities? There should be a reason why you are doing that. So tell us, look at the background of this patient. Bronchiostasis, kyphoscoliosis, and they've got CAP and everything. So anything we can, what can we make of that? Yeah, I'm on the box chat box now. I'm trying to see any response that are coming through. I'm reading. Yeah, PT Physent, review investigations, chest X-ray, ABG, venous blood gas where relevant. Yeah, full blood count, electrolyte. Yeah, all these things will be really very interesting for us to see before we draw our treatment. If we'll be treating them, we don't know yet if we'll be treating them. We're still listening together. Yeah, so lovely stuff. So now, anything, I just want us to relate their patient background. Think about, okay, let me give a clue. Think about the respiratory load I said earlier, respiratory load, patient respiratory capacity, and correlate those things together. Respiratory capacity and respiratory load. Think about those things. There was a reason why I put that in the slide. Think about that. It's just to be, yeah, PTM to know their pre-morbid respiratory capacity, okay? Before they are being sick, how are they? They've got bronchiostasis. And what does that mean? This is how we are thinking. Before this lady come to the hospital, before they came into the hospital, before they are admitted, they've got bronchiostasis. They've got, what else have they got in there? They've got kyphoscoliosis. What does that mean? What does that mean? What does it really mean? This is how you think when you see patient, even stroke patient that we see on a regular basis, acute patient level, stroke patient, they are coming to the hospital and they've got this condition, link those conditions with what they are being treated for. You can judge, oh, this is why they easily get fatigue. Oh, this is why they are this is why they are that. This is why they are struggling to tolerate this exercise. This is how we think. We don't just read comorbidity and say comorbidities. No, link them to, oh yeah, PTI might lovely stuff. A, ability to cough, audible secretion, volume, color, yeah. B, respiratory breathing pattern, SpO2, use of accessory muscles, chest expansions. Since there is kyphoscoliosis, lovely stuff. Thank you very much. Absolutely brilliant. I love that. Now, this is one of the questions I'm asking. This really answered that. Somebody have got kyphoscoliosis at their baseline before they even have issues with CAP, with pneumonia now. Normally, they are struggling to, what is that? They are struggling with thoracic excursions. Like, think about that. What impact will that have on their chest? They might be struggling with that full thoracic excursion or expansion, whatever you want to do that, whatever you want to call it. They might be struggling with that. And again, on top of that kyphoscoliosis, they've got bronchiostasis on top of that. Oh, not on top. In addition to that, not on top. In addition to that, they've got bronchiectasis. What does that mean as well? I need more answer to come through. I'm happy to waste the rest of the time, not waste. I'm happy to use the rest of the time on this because I really want us to start building that clinical reasonings and confidence in seeing some of these patients. Yeah, other area as written by PT Hamad, lovely physio. See, heart rate, blood pressure, capillary refill, perfect. Yeah. D, you are looking at, are they conscious? Are they unconscious? Are they responding to pain? Yeah, ACVP kind of thing. Lovely stuff. E is temperature. Yeah, temperature. Yeah. Yeah, PT Emily. Yeah. Emilia, implications. He has a primordial low respiratory capacity. Absolutely brilliant. You see, somebody is coming from background bronchiectasis, so he's got scoliosis. On top of that, now we are doing respiratory. I deliberately put that total knee replacement kind of things there. I deliberately put it there. Don't be distracted with that for now. Don't be distracted. Yeah, it could mean, yeah. Again, if you really want to link that up, it could mean total knee replacement. How are they functionally? Are they mobile? Are they independent? The fact that they've got knee replacement does not mean they cannot be doing their lifetime. Yeah, link, but don't be knee replacement. They might not be. No. But then again, we also need to also know into their baseline mobility and everything, social history, all this kind of is really important. But respiratory wise, now this lady is coming from a poor respiratory background. Remember that respiratory capacity. Now they've if you look at already before they are admitted, they are battling with respiratory impairment. They are battling with kyphosis, scoliosis, kyphosis. They are battling with bronchiostasis. What question will you be asking family, even if they cannot verbally communicate with you because they are struggling at the moment at the bedside? You want to quickly ask because they normally use steroids or what do you call it? How are their chest clearance normally? Are they able to cough and clear normally? How is their secretions? Are they normally? Some people might even be needing oxygen at home. Some people might be needing nebulizers. You are asking those respiratory questions. Are they normally short of breath? This is why you are asking. These things will help you to make your clinical reasonings. Somebody has been struggling, and again, it might not necessarily mean they've been struggling again, but somebody may have been struggling before coming to the hospital. Have you asked those questions to understand their respiratory background? That is respiratory capacity. You know from their capacity before they came in. And again, in terms of load, on top of that now, you've now got extra load. What is that extra load? CAP, community acquired pneumonia, knocking that moderate or low baseline, knocking it down. How do you think they will be presenting? They might likely, in your head, you think, if I'm on phone, if you are on phone with me, you are giving me that baseline. This is how I think. This is how I think. How you see your patient will matter in the way you are treating them. It's going to guide in the way you will treat them. If I'm on phone and you are telling me, somebody have got COPD, they are chronic smokers, they smoke about a lot of cigarettes every day, they have MNDM, and you are giving me all those kind of things. Okay. And now you say, okay, let's say normally people will start with, they have been admitted in the hospital because of this chest infection, blah, blah, blah. But now, okay, tell me their comorbidities. They've got pneumonia, they've got motor neuron disease, they've got bronchiectasis, they've got COPD. I'm packing everything together. In my head, I'll start thinking, okay, I know where they are coming from. They are coming from poor background. Now, poor background, what is on top of that now? Another infection that is likely to knock them down, to further knock them down. Now, if you now think about some other patients, they are coming from good background. If they are coming from good background, they are likely, you can go to them. That means in terms of reserve, in terms of physiological reserve, in terms of resilience, the one coming from very, very good background, they are likely to have that strength to recover quickly compared to somebody coming from, I don't know if somebody is getting these things. This is how we think, and this is how you need to be thinking. This is how you need to start seeing your patients. Now, this 10 patients now is now fatigued. On top of they've had issues previously before they came in, they've had something on top of their issue. Now they are struggling with breathlessness and fatigue. And their oxygen is not even optimized at the moment. They are just deteriorating. So what will you be doing treatment-wise? I know people have written that. What will you be like they are fatigued. You, of course, you will do A to E like you guys have mentioned. You will do your A to E like everyone have said. Peter Ahmad have written a whole lot of lovely things for us. You do all those. You do your systematic assessment, A to E assessment with them. Great. You look at their work of breathing. You ask for ABG. At the moment, they have said oxygen. If you are on phone you and you are saying they are on oxygen, that's very big. What amount of oxygen? I have to know. Because that will also inform me if I will be coming to see your patient or not. What amount of oxygen are they on? I need to know that. I need to know that at the moment. Okay, I can even ask you going forward that if now as we are increasing the amount of oxygen, what is happening to them? Are they becoming more drowsy? Are they getting more fatigue? If they are getting more fatigue, remember hyperoxic drive. I have explained, go back to that ABG kind of thing. Sometimes there are some patients, as you are going higher on oxygen, they will start getting fatigued. they'll become more and more fatigued. Oh, that should tell you something as physio. Yeah, that might be a case of hyperoxic drive, PQ issues, kind of things. Those hypotheses. Because I have explained in the past, you don't want to give them more oxygen that will further knock their, what do you call it now? That will further knock them down into hypoxic drive. You want to be careful. Okay? So we are at the bedside now, they are fatigued, they are work of breathing, everything is just good. What do you want to do with them? Okay? Of course, they've been clarified that they are for full escalation, which is great for them. In terms of treatment, you see if there's anything you can quickly do at their bedside to optimize them. In terms of treatment, do you want to start? Okay, I'll ask this. I won't answer the question. Do you want to start from low ladder? Do you want to start climbing ladder up? Or you want to, like for this kind of patient group, they are fatigued at the moment. Do you want to go to their bedside and start doing ACBT, deep breathing exercises? Do you want to do low level treatment, or you want to jump to the top of the ladder and start treating them? What do you think? If you are going for low, there is no right or wrong. Let me tell you. Generally, the fact that doctor has said they are fatigued does not mean I cannot go. But usually, okay, if you are going for low level, why will you go for your low level treatment? Low level like bottom of the ladder. If you are going by top level treatment for them, why will you be going for top level? There is no right or wrong. I just want to see those clinical reasoning kind of things. Your ladder is your toolkit. You've got a lot of things in your toolkit. We have talked of our cover assist is in your toolkit. You have talked ACBT is in your toolkit. Deep breathing is in your toolkit. Everything, position is in your toolkit. Everything, physio, mark, percussion, manner, everything is there in your toolkit. Will you be going from, are you thinking going from low level to top level, if you can work, or you think top level to bottom level will be more appropriate for this patient? What do you think? Theoretically, what do you think? Yeah, PT Aisha assess their posture. Yeah, posture is really, how are they presenting in the bed? They might even be slumped in the bed. Somebody struggling to ventilate and you are finding them slumping. What is the first thing you want to do as people? Get them upright in bed. Get them upright, because you know that when they are in upright position in bed, the bed is not there to crush their chest, or that they can have that nice thoracic expansion, and they can maybe that may even improve their ventilations and even oxygen requirement. I mean, a lot of time. Okay, baseline exercise tolerance. Yeah, you need those things. Yeah. Community home assessment. Yeah. Community home assessment. Yeah, is really good, but that will get their baseline function and everything. Yeah, good. Really good stuff. So what do we think? Low level treatment or top level treatment or high level treatment? What do we think, guys? Time is running. What do we think? Let's finish this question and go. What do we think? Just want those clinical reasoning kind of things. What do we think? Yeah, I will start with low level treatment. So great, that's PT Modi. So why are you, PT Shalom? So why are you starting at low level treatment? Yeah. Why will you be commenting them on low level treatment? Yeah, there's no right or wrong. It's just clinical reasonings. That is it. PT Shalom will be starting them low level treatment. Why is it going for that? Yeah. Let's finish up. There's no right or wrong, like I mentioned. Feel free to pop your reasoning, your clinical reasoning down there. Who is helping us? Where are our lovely physios? Where are we? This is our patient. Okay. I think I've explained slightly on how we see things. Somebody coming from respiratory background, they've had another thing trying to knock them down. Yeah, they are fatigued. Yeah, they are fatigued at the moment. They are this thing. Yeah, I might just go and see. Yeah, what can I really do? Their cough might be weak. Do I need to function them? Do I need? Do they need MP? Do they need? They cannot tolerate MP. Okay. Do I need to do Ganga? Do I need to? Generally speaking, I might want to do
Yeah,
top.
let's go.
Sorry. So I might want to do top level, going from top to bottom. I might want to just see, yeah, what can I really just do to support their core, first of all, because I know they might be really, really fatigued. Their core might not be really, really very strong. But if I am the best idea, I can see that, yeah, it's not really that bad. Yeah, I might still do low level from them, but again, look at where they are coming from. Look at how they are presenting and make those decisions at their bedside. Time is going. This is chest X-ray. This patient have gone ABG here. This is what ABG is saying. This ABG, this pH is low. This oxygen is low. This CO2 is high. This is a case of type 2 respiratory failure. This patient needs to go on NIV. So they have commented this patient on this. This is their tidal volume. The tidal volume, you can use that to monitor where they are doing in terms of what is it, in terms of their IPAP. Okay, the oxygen will be there. Also, oxygen can also be entrained through this device to support their oxygenation. You can support their oxygenation with FiO2 you are giving them, or with the EPAP. Those ones can be used to support their oxygen. I won't go through this because of time. I think I'll just stop there today. Thank you very much, everyone. I'm happy to take questions. So I can't do ventilator. That's it. All right. Thank you very much. That's it. Any question before we close
Thank you, sir.
All right. Appreciate. Thank you. Thank you for joining as well. All right. Hopefully we can take some of the knowledge gain to improve patient care, how we see them, and provide for the optimization. All right. Thank you for joining, everyone. All right. Take care.
Thank you so much. Thank you so much,
Thank
sir.
you, sir. God bless you in Jesus' name.
Thank you, sir.